Yeah, hi winners. Hope you're doing good. So this is Dr. Srikanth from Team Mdsconquer. So now I'll be discussing one of the most important topic of the pedo in integrated with oral path and oral medicine, which is nowadays very frequently asked in the examinations. Let it be a national boards, or let it be your NEET or INICT or any sort of license exams. This is one of the most commonly asked clinical based question. So before jumping into the topic, so learning is a beautiful process. It is nowhere related to the age of an individual or a position of an individual. If you have the will to learn, okay, the things around you will change. Okay, so I strongly recommend every one of you to inculcate this particular habit of learning from the surroundings or learning from the people around you, and start implementing them in your professional as well as in your personal life. So the topic of discussion for today is MIH, that is molar incisor hypomineralization. So you have hypomineralization, which is more of an focused on area specific, that is molars and incisors. So before going into the content, you have a case here, okay, a 9-year-old Brazilian boy with a chief complaint of yellow colored patches on maxillary mandibular centrals, laterals and first molars as shown in the above clinical photograph. His mother gives no complications during pregnancy but has a flu with a high fever of 103 degrees Fahrenheit for more than a week during the first year. So what is the diagnosis and treatment plan? Of course, the diagnosis is very simple, that is MIH. The most important aspect in this particular question is Brazilian boy. Why it is being mentioned? It's very simple. The prevalency of MIH is more in these individuals. One. The second important aspect is area specific. Okay, this occurs area specific. The hypomineralization is being occurring in area specific. That is your maxillary, mandibular, centrals, that is incisors, and your first molars. And of course, they have a background etiology that there is high fever at the age of 1 year for more than a week. That can be the etiology in this particular case. So this is all about MIH. So we'll try to wrap up this MIH as fast as possible, and we'll try to discuss few other hypomineralizations within our limitations in the differential diagnosis part of this particular disease. So first and foremost thing is about enamel, because enamel is the most commonly affected structure in this particular MIH. So enamel E for ectoderm. So enamel is ectodermal in origin. And coming to M for mineralization. So enamel is having the highest mineralization among the structures. You have enamel, dentin, cementum and alveolar bone. So if you list out the mineral content or mineralization aspect, enamel is having the highest mineralization. Okay. And second thing, enamel does not have the ability to regenerate after it is lost. Okay, you cannot regenerate enamel. And of course, enamel is formed from ameloblast. And this ameloblast is very sensitive. It is very sensitive to the external environment. It is very sensitive to the infections. It is very sensitive to every aspect. And in which stage they can ask you? That is in the formative stage. So enamel has different stages of formation, which will be discussed in your dental histology. So enamel is very sensitive in formative stage, and it shows its reactions in the form of hypomineralization or hypocalcification or hypoplasia. And all these are the abnormalities that we regularly see in the enamel. So jumping into the next aspect, definition. So basically the definition of definition of this MIH is the hypomineralization plus systemic origin plus first permanent molars 1 to 4, any of these, mostly 4, if not at least 1, 2 or 3 or 4, plus similar features can be seen in the case of your incisors. So this is basically the definition of hypomineralization. They can ask you a diagram based question. It is focusing specifically on the incisors as well as your molars. In some cases, there are chances that it can be seen in the case of canines, it can be seen in the case of premolars, tips of canines and premolars can also be affected. But most commonly, according to the definition and to the undergraduate level, okay, so the question will be systemic origin plus your like your permanent molars, okay, the first permanent molars followed by the similar features can be seen in the case of your incisors also. So this is basically MIH. So the next important aspects are other terms related to MIH which are given by the different scientists and which are present in the standard textbooks. The first one is, of course, molar incisor hypomineralization, previously used to be termed as an abbreviation called as MIH. The next important term is about non-endemic stained enamel. The next one is idiopathic enamel hypomineralization. And the next important is demineralized first permanent molars, because it's most commonly affected in the 4 first permanent molars. The next important aspect is they can give it as cheesy molars. The molars in the clinical photograph appears like cheesy. They appears like cheesy. So you have other types of molars which are again questions asked very frequently. Moon's molars, mulberry molars, or fortuner's molars are your the molars which are seen in the case of congenital syphilis. So congenital syphilis is Moon's molars, mulberry molars, or your fortuner's molars, whereas cheese molars are the term that is very specifically given to MIH. And the next important terminology is hypomineralized first permanent molars. Okay, so these are the other terms, and very frequently nowadays this question was asked in INI CET. What is the other term of MIH? They are non-fluoride hypomineralization. It is non-fluoride hypomineralization. It's nowhere related to the fluoride. Okay, so these are other terms that you have to make a note. Okay, and the next one is coming to etiology. So etiology, there are different types of etiologies, and there are studies which are showing the background history, particularly the medical problems during the pre or peri or postnatal periods. Okay, so that can be an infections. Very frequently the case-based questions can be integrated with a respiratory infection to the individual or a viral infection. Okay, they can tell you the patient is having fever, they can tell you the patient is having a viral infection with fever, or they can tell you the patient is having asthma or any sort of respiratory illness. Okay, so these are the most commonly or frequently asked the medical issues associated with pre, peri and postnatal periods. Okay, of course we'll discuss them in detail, but these are the things that you have to focus on. The next important thing is relation to the fluoride. Okay, so MIH chances will be less in the individuals who are exposed to more fluoride. It's very simple. The fluoride content increases during the particular period of growth. The MIH chances will decrease. The next one is antibiotics. There are few antibiotics which can lead to MIH, particularly the antibiotics which are mentioned in references are your penicillins, particularly amoxicillin, and followed by your erythromycin. Okay, so both of these, and there are few drugs which are basically associated with the hypomineralization can also lead to the MIH, but specifically it is antibiotics which are related to, that is amoxicillin and your erythromycin. Okay, so next important aspect is breastfeeding, prolonged breastfeeding. Okay, so if the individual is having a prolonged breastfeeding, okay, so there are higher chances of occurrence of MIH because of the lack of calcium. Okay, so prolonged breastfeeding can cause okay, so you can add a note about prolonged breastfeeding. So then comes the next one is environmental toxins. There are few environmental toxins which can also cause this. Okay, so environmental toxins, particularly they were named as polychlorinated biphenyls or your dioxins. Okay, so both of these are responsible for occurrence of MIH. So then comes the socio-economic background. Okay, the economical background of the individual, The economical background of the individual can be like if they are originated from low socioeconomic status, because of lack of nutrition, proper nutrition during the growth period, there are high chances of occurrence of MIH. So here you have to focus mainly on the aspects related to respiratory illness or the fever or viral infections as prenatal. As fluoride content increases, the chances of MIH decreases. You have 2 antibiotics and you have 2 environmental toxins, and of course prolonged breastfeeding or the primary etiologies for occurrence of this particular abnormality. Then comes, as I said, like it can be due to the poor health or any systemic medications, or the mother is having nitrous oxide during the pregnancy, during the delivery, and the birth complications. Okay, so the birth complications can lead to MIH. That can be your hypocalcemia or asphyxia related to the respiratory system, or the period of labor, prolonged period of labor. The patient is having high fever, respiratory illness, that can be related to asthma or ear infection, that is otitis media, or systemic fibrosis, renal diseases, or viral diseases like chickenpox, measles. All these can be the background history they can give in the case-based description. I'm primarily focusing the list of these things as a case-based aspect. Okay, no need to mug all these things. It is more logical. They can ask you mostly a case-based or a treatment-based question on this. They can be like preterm baby. Okay, preterm baby is nothing but less than 37 weeks. Very frequently asked, what is preterm baby? Preterm baby means less than 37 weeks, or low birth weight. Low birth weight is nothing but less than 2.5 kgs or 2500 grams. Okay, so these are the main medical related pre, peri and postnatal disorders which can lead to MIH. They can be considered as an etiology. The most important aspect is respiratory origin diseases like asthma and cystic fibrosis, or viral diseases, okay, or fever, prolonged fever can be an etiology for occurrence of MIH. So next one is jumping into the clinical presentation. Enamel hypoplasia are familiar. So diagram based, very specific to incisors and molars, that can be easily handled. And now these are the criteria that are given by the European Association. Okay, so the criteria includes these things. Okay, I'll be discussing these things in a descriptive part because your questions will move around these areas. Okay, so you'll have opacities clinically visible. You have post-eruptive enamel breakdown, that is very, very important. So in most of your hypomineralizations, whatever discussed in your oral path and oral medicine, the enamel breakdown occurs before the eruption or during the process of eruption. But here, the enamel breakdown will occur post-eruptive, means after the eruption, the enamel breakdown is going to occur. And you will have atypical restorations. You will have restorations which are not normal, which are quietly abnormal. You see the abnormal restorations, the margins are being extended. You will have patches of restorations here and there. So that is very specifically called as atypical restorations. And of course, the patient may complain of extractions of molars that can be due to MIH again. Or sometimes there will be eruption failure of molars or incisors. So these are the main clinical presentations of MIH, okay, or the clinical criteria for the presentation of MIH. As enamel is lost, the patient most commonly complaint of pain or hypersensitivity. Dentinal hypersensitivity is the most common complaint because enamel is lost and dentin is being exposed. So whenever the dentin is being exposed, the patient will have pain and hypersensitivity. So these are the main important aspects in the clinical presentation. Okay, so luckily in the clinical case what we have discussed, the patient doesn't have any symptoms. The symptoms were not mentioned. The patient consent is aesthetics, that is your first point. Opacities, yellow color patches are seen. So then jumping into this, this is given by European Association of Pediatrics, Pedodontics. Okay, so already discussed, that is your discriminate opacities, okay, post-eruptive enamel breakdown, atypical restorations and extractions, extracted molars because of this particular lesion. Okay, so these areas are very, very important. I want you to focus on. Everything is self-explanatory. And abnormality in the transparency of enamel identified as creamy white or yellow to brown color opacities. These are the particular terms, creamy white or cheesy white. That is the reason why these are called as cheesy molars. which with clear and distant borders adjacent to the unaffected enamel. Okay. The second one is, I told you there will be enamel breakdown, that is disintegration of enamel following the tooth eruption, potentially resulting from the masticatory forces, because the enamel here, it is very thin or very weak, that is fragile enamel will be there, it will be easily break down. And coming to the atypical restorations, which I have already explained, that is basically the size and shape of the restoration is not confined. Normally, if you prepare cavities or if you dig out the enamel and if you start giving the restoration, the margins are very distant. Okay, you can clearly tell this is the boundary of this particular restoration. But when you're talking about atypical restorations, which are seen in the case of MIH, you don't have proper boundaries, you don't have proper, the borders, the refinement will not be there. Okay, in most of the cases, the extensions can be on the buccal and the palatal smooth surfaces also. Right? Normally, we don't have the caries lesions or cavities which are extending mostly on the buccal and palatal. Very rarely we see this buccal extension, palatal extension cases in your clinical scenario in the departments also. Okay, so that is very important when you're talking about extractions, basically due to extraction of molars or extractions of incisors, basically due to this breakdown the patient is going to give in the form of a history. So these are the very important criterias of MIH that you have to make a note, because questions were asked on this particular table in INICET recently. So then apart from this, there are a few other things which we have to discuss, particularly about the thickness and other aspects. So as already discussed, most of these areas, the areas affected are occlusal surface of molars and can be seen on the buccal or labial surface of incisors, which we can clearly appreciate in the diagram. Cheesy molars. Cheesy is mostly on the occlusal surface. Okay. So next one, the extent of involvement. The extent of involvement, they can ask you, the extent of involvement in the enamel can be in the range of thickness of 1/3 to 2/3 thickness. 1/3 to 2/3 thickness. And there are few important, the defects less than 2 millimeters. If you see enamel defects less than 2 millimeters, they are not considered as MIH. Defects less than 2 millimeters are not considered as MIH. Okay. So the next important point that you have to make a note, because the questions can be asked, because the questions were already repeated in few examinations on this particular area. So I want you to make a note about these aspects. That is the cuspal inclinations. You see, this is the cusp. This is the cusp tip, and these are inclinations. Okay, the inclinations are affected, but not the cuspal tips. The cuspal tips are not affected, okay, in this particular individuals. And of course, it is more commonly seen in the case of molars compared to incisors, that is your first permanent molars. And sometimes you can see these extensions on the tips of the canines as well as the premolars, but it is very, very rarely. But this type of presentation can be seen in the primary dentition also. Okay, it can be seen in the primary, it can be seen in the permanent also, more commonly seen in the case of molars compared to the incisors. Cuspal tips are not affected, inclinations are affected, less than 2 millimeters are not considered as MIH. Extended defects can be from 1/3 to 2/3 thickness of the enamel, most commonly seen on the occlusal surface of molars and buccal and labial surfaces of incisors. So these are the important things that you have to make a note clinically. Okay, they can ask you questions on these areas. Next one, there is something called as severity grading of MIH. MIH has been divided into two severities, that is mild and severe. Okay, mild is discriminate enamel opacities without enamel breakdown. There is no breakdown of the enamel. Okay, the patient may have occasionally sensitivity will be there. Next one is second category, discriminate enamel opacities with the breakdown. The patient will have spontaneous hypersensitivity affecting the function, aesthetic problems and everything. Two categories, mild and severe. There are different types of index scales that are helps in distinguishing this MIH, but they are not much important from the examination point of view. So we can stick on to these areas, particularly your clinical criteria, what I have discussed according to European Association of Pediatrics is very, very important from examination point of view. So as already said, it is more inclined to the permanent dentition, but can be seen in the case of deciduous teeth also. That is your deciduous molar hypomineralization. That is, enamel hypomineralization is also reported in the primary teeth. Okay, and you can see the clinical photograph where both primary as well as permanent teeth are being affected by hypomineralization. Okay, in permanent dentition, it is the first molars which are most commonly affected. Whereas in the case of your primary dentition, it is the second molars which are most commonly affected. Your second molars are most commonly affected. Very rarely incisors are going to get affected. Sometimes the primary canines as well as first molars. The most important area is the teeth which is most commonly affected by MIH is your permanent molars. The teeth which is most commonly affected in your primary dentition is your second primary molar. Coming to differential diagnosis, this is utmost important aspect according to me, because questions on MIH, yes, chances are there, but questions on other hypomineralization or other effects of enamel are very, very frequently asked in the examination. Okay, so coming to differential diagnosis, apart from MIH, what are the other areas where your enamel is being affected? The first and foremost thing is amelogenesis imperfecta. Okay, you can see amelogenesis imperfecta. The unique property of amelogenesis imperfecta is all the teeth are affected. You see, all the teeth enamel part is being affected. You can see in the clinical photograph. That all the teeth. Okay, you can see all the teeth are being affected. Okay, the first. The second thing is the family history will be there, because amelogenesis imperfecta is basically origin defect from the genes. Okay, so it is carried from generations. So you can ask you whether the parent. So in this question again, they are going to give you the mother is having the same clinical feature, or the mother is having the same complaint, or they can tell you the siblings are having the same complaint. So family history will be present. And the utmost important thing, again, you can see the radiographic appearance of amelogenesis imperfecta when compared to MIH. MIH does not have a drastic changes in the radiographic picture except the defects in the enamel. Whereas you see amelogenesis imperfecta, you will have a taurodont appearance on a radiograph, which helps in differentiating the MIH from amelogenesis imperfecta. Important points: all teeth affected. MIH, only incisors and molars are affected. Next one, family history will be there. Here, no family history will be there. Okay. Next one is fluorosis. Okay. So fluorosis are basically is origin from a background or a region where there is high fluoride exposure to the individual. So they can give that as a background information. Okay, and the number of teeth affected during the fluorosis, in the fluorosis case, depends upon the time of exposure. So this we will be discussing in the pedo and integrated with your fluorosis and all these things. The pedo integrated with community part, we can discuss which area, which duration. If an individual is being exposed to fluorides or individual is exposed to tetracyclines, so there will be stains. Which teeth are affected? So this is again a table. This table is there, very important from examination point of view. Okay, the table is there. Very important, particularly if you are preparing for national boards. So this correlationship table is very frequently asked. Okay, so the number of teeth affected depends upon the time of exposure and the amount of fluoride that is being exposed in these individuals. Okay, that is how you can differentiate the fluorosis case. And followed by, there is something called as enamel hypoplasia. So enamel hypoplasia can be partial, affecting only few teeth, or can be complete affecting all teeth or affecting the entire part of enamel. So how can you differentiate this? So this enamel hypoplasia is basically occurred at the time of eruption. And what we have discussed about MIH is post-eruption. Means the individual will have a normal enamel, and over a period of time during the mastication process, MIH will be detected. Whereas enamel hypoplasia will be seen at the time of birth. Time of eruption. During the time of eruption, at the birth or during the time of eruption, you can diagnose this enamel hypoplasia. So the next important aspect after enamel hypoplasia is, of course, your MIH. MIH, we have discussed a lot about MIH. MIH is basically seen in the case of molars compared to incisors. And how you can, like a severe form of MIH, which is affecting all the teeth, you may get confused with amelogenesis imperfecta. So amelogenesis imperfecta and a severe form of MIH looks same, because I have discussed the severe form of MIH can affect all the teeth, including the canines as well as the premolars. Okay, so now you can differentiate only with the help of radiograph, because radiographic presence are there in the case of your amelogenesis imperfecta, and these radiographic appearances will be absent in the case of your periodontitis. Sorry, absent in the case of your MIH. Okay, so that is how you can differentiate a severe form of MIH to that of amelogenesis imperfecta. So next, one more important, most frequently seen is white spot lesion. What is white spot lesion? White spot lesion is called as insufficient caries lesion or initial caries lesion, that is basically occurring due to the drift or change in the remineralization cycle. You have something called as remineralization cycle. So whenever your remineralization cycle is most commonly shift to demineralization side, okay, then there is high chance of occurrence of white spot lesion, and white spot lesion can occur anywhere on the labial surface or anywhere on the teeth, but most commonly occurs on the cervical areas. Why? Because plaque accumulation and chances of changing this demineralization cycle will morely seen in the cervical one third. Okay, so white spot lesions can be seen in those areas where the plaque is being accumulated and there will be intact enamel, but there will be subsurface demineralization. So white spot lesion is also called as subsurface demineralization. It is more often related to the initial steps of the caries, but most of the things whatever we are discussed are not related to the caries. They have high chances of caries occurrence by presence of MIH, high chance of caries occurrence will be there. Okay, but this is process of caries. Okay, so that's about white spot lesion. The next comes is Turner's hypoplasia or Turner's teeth. Don't get confused with Turner's syndrome. Turner's syndrome, I hope like you know the Turner's syndrome, that is 45XO. Okay, right, 45XO is a Turner's syndrome. This is Turner's hypoplasia or Turner's teeth. Okay, here you can see a particular teeth is being affected from its shape and form. Basically it is due to the trauma. There are few textbooks telling it as traumatic hypomineralization also, or traumatic hypoplasia. One of the reason is trauma. Okay, and other reasons can be many other things, the changes during the primary dentition. So this is most commonly seen in the case of permanent premolars, because primary molars are most commonly affected by dental caries, and the infection from primary molars will reach the periapical area, and which is going to affect the fellow. We have discussed the fellow, that is ameloblast fellow will get affected and it will lead to Turner's hypoplasia. This is localized enamel hypoplasia, means only a particular teeth, only one teeth or two teeth are going to get affected, and preferably most commonly seen in the case of mandibular premolars. Area specific, it is mandibular premolar. MIH, molars, permanent molars. Okay, so this is how you can differentiate Turner's hypoplasia from MIH. Next comes, of course, questions very frequently as recent NEET examination. There is a question on this, right? Coming to the syphilis. Okay, so these are the features which are seen in the case of congenital syphilis, and of course you are very familiar with the triad of congenital syphilis. So you have incisors as well as molars are affected. Similarly, coming to area specific, syphilis area specific, they can ask you the combination. I mean, the common thing that you see in the case of congenital syphilis and MIH is area of occurrence. So it can be occurred, your abnormality of teeth can occur in incisors as well as in the case of your molars in the syphilis also. So incisors are called as Hutchinson incisors. Okay, so you'll have a notch like this, and molars are called as Mulberry molars, or they can be called as Moon's molars or Fortuner's molars, okay, which are seen in the case of your congenital syphilis. Okay, that diagram based question, or they can give you the background history of syphilis to the mother, or they can tell you that the mother is regularly having an unprotected sexual contact. They can give some features of syphilis. Okay, you have lots of things about syphilis which are discussed in oral path and oral medicine part. You can do that, right? So these are the important differential diagnosis part. Coming to the clinical problems, until now we have discussed the clinical criteria and everything. Clinical problems, I said, like enamel lost. What is the problem if enamel is not there? Anyone, like you and me, your parents will have a loss of enamel. Okay, what is going to happen? The patient is having dentinal hypersensitivity, and of course, if severe loss, the patient is going to have breakdown. The pain will be there. Pain and sensitivity are most common complaints, and of course, these are seen as a post-operative breakdown. Okay, so the patient have difficulty in mastication. So these are some clinical consideration. Are more prone to caries. Enamel is weak, more prone to caries. Enamel is weak, discolorations, more prone to poor aesthetics. And need recurrent treatments, because all the teeth will not get affected by the same time. Okay, so destruction will be at different phases, so recurrent treatments are required. So these are the clinical problems associated with the MIH. And coming to the treatment plans, okay, so treatment plan of MIH is very simple. Okay, so don't write heavy notes. Okay, so try to understand the content. Once you understand the content, it is very easy to answer. So MIH can affect the permanent molars, that is first permanent molars, FPM. FPM is very commonly used term for MIH, that is first permanent molars hypomineralization. Okay, next one, incisors are affected. So incisors are mostly concerned with aesthetics, whereas molars are mostly concerned with masticatory procedure, that is your mastication. So without breakdown, okay, that is post-eruptive breakdown, post-eruptive. So enamel, there is no breakdown of the enamel. So one category, there is no breakdown of the enamel. Second category with the breakdown of enamel. And coming to the incisors part, we have discussed, one is cheesy or creamy white defects are there. Second one is brown color, yellow brown color defects are there. Different treatment plans. One is prevention. Second one is restoration. And third one is rehab. Okay, so these exact terms we'll be discussing in the community, handicapped, rehabs and everything we'll discuss in the community part, the first chapter of community. Okay, so prevention, basically it is preferred to advise the patient to go for high fluoride containing toothpaste, that is around 1000 to 1500 ppm fluoride content has to be given to the kid. Okay, so this is going to help in remineralization process, because what is the problem here? Hypomineralization. And what you have to do, you have to encourage the remineralization. The best source of remineralization for us is, of course, the fluorides, or you can use CPP, ACP, or you can use other things which I'll be discussing now. Okay, so that is the most important aspect. And coming to the FPM, that is first permanent molar hypomineralization without enamel breakdown, what you are going to do is fluoride application you can do. Okay, that is topical fluoride application you can do, or you can advise pit and fissure sealants. This is the preventive aspect, because there is no enamel breakdown. So don't disturb the enamel until it is, you try to remineralize the enamel, because enamel can break down because there is lack of mineralization in it. So what you have to do, you have to feed the enamel with the minerals. That can be done with topical fluoride application or any other things like remineralizing agents can be used. There is no need of restoration, there is no need of rehab. Next one, first permanent molar hypomineralization with the post-eruptive breakdown. There is a breakdown here. So when there is a breakdown, what you have to do, you have to do a restoration. So what restoration? GIC can be given. Okay, so GIC can be used as an interim restoration, not a permanent in MIH. GIC can be used as an interim, and further you can replace it with a nice, good adhesive composite restoration. So that is about the restoration. Or sometimes there is a drastic loss. Breakdown can be minimal or breakdown can be complete. So when there is very large breakdown, then you have to plan for the rehab with the porcelain fused crown, or you can go for a cast metal restoration. Okay, or you can go for an extraction followed by orthodontic treatment. Extraction followed by orthodontic treatment is nothing but assuming that the patient, take a radiograph, patient is having third molars. What you try to do a balanced extraction. Okay, if it is already affected, then you try to drag the second molars to the first molars and third molars to the second molars position with the help of ortho treatment. That is called as extraction followed by ortho treatment. Okay, the next important aspect is incisors. Okay, so when you're talking about incisors, again you have two important aspects. One is white creamy defect. Okay, so second one is brown yellow defect. Okay, right, so we are done with the molars. Now we are talking about incisors. So incisors, the main concern for any one of us is aesthetics in incisors. So coming to aesthetic point of view, you have two different aspects. Okay, one is you have white creamy defects. Second one is you have brown yellow color defects, which I am going to discuss detailedly because they are mainly concerned with aesthetics, and aesthetics we have different types of treatments. Okay, I'll be discussing in the next few slides. Okay, and of course we are already done with this. Extraction followed by orthodontic treatment is nothing but because of gross destruction or grossly affected or severe form of MIH. Okay, so you are going to extract these molars, or molars particularly. So before extraction of molars, you have to take a call whether the third molars are present or not. Age of individual and everything has to be taken into consideration. So OPG has to be taken and third molars existence has to be confirmed. So then you extract the first molars, replace the positions of the first molars, second molars and third molars to the position of first and second molars by orthodontic treatment. This is what extraction followed by ortho. And of course, I'm talking about the aesthetic considerations for the anterior teeth: creamy white, yellow brown color, or opacities. Okay, so the three aspects which can be seen as a clinical features in the case of your MIH. So three different treatment plans. The first one is creamy white opacities in a kid less than 15 years. You can do microabrasion. Microabrasion, basically you have to use, preferably this has to be used, 18% of HCl. In very few conditions you can use 37% of phosphoric acid, but I want you to stick on to 18% HCl. There is something called as microabrasion modified Krol's technique, okay, which we have already discussed. So modified Krol's technique, what he has used 11% of HCl. So the updated answer is 11% of HCl. If you don't have 11% of HCl, then you have to go for 18% of HCl as an answer, which is already covered in your operative window, okay, which is already discussed in your operative window part also. Okay, so do make a note of it. Very important question, was repeated so many times in the exam. So apart from this, whenever you have a creamy white opacities, okay, so the technique that you can use, resin infiltration. Okay, so this is resin infiltration, very very important. Okay, an updated version, not at a UG level, at a PG level it is there. So there is resin infiltration. Whenever you have a defects in enamel, whenever you have a minimal defects in the dentin, you can infiltrate the resin into the porosities. So that is called as resin infiltration technique. Or you can try tropical fluoride application or CPP ACP, that is your remineralizing agents. Okay, remineralizing agents. CPP ACP is also called as tooth mousy, in the form of a tooth mouse in the form of a paste, or recal dent in the form of a chewing gum. This is chewing gum. And tooth mousy is a paste that you can use it. Okay, so the next important aspect is yellow brown color opacities in less than 15 years. Since the defects can involve full thickness of enamel, microabrasion cannot be so effective. Okay, white CZ, outer surface you can do it, but lower part microabrasion, single microabrasion may not be effective. So you have to do 2 to 3 treatments of microabrasion. Then you have to go for composite restoration, or then you can try the veneers and all these, keeping the aesthetics into consideration. The next one, opacities more than 15 years. In these individuals, you can really try this bleaching technique, that is 10 to 15%. 10 to 15% is the range. Okay, 10% is the best answer. That is 10% of carbamide peroxidase can be performed as a bleaching aspect before you start your composite veneers or anything. Okay, so these are the important aspects about the treatments. Okay, right, so I hope you're clear with this content. So just a brief outline. Okay, so MIH, the most important aspect, it is area specific. It is most commonly seen in the case of permanent first molars and incisors. Okay, and MIH has a background history, that is systemic origin. It is okay. So you have some etiology factors. The most important etiology factors that they can give is fever or respiratory illness. They can mention it as an asthma. They can mention it as a cystic fibrosis, respiratory system related origin diseases, or a viral fever, or a fever of high fever for an individual at a particular age. And followed by, there is some criteria for this. Okay, so the criteria, 4 or 5 important aspects, let it be opacities, let it be post eruptive enamel breakdown, or let it be atypical restorations, or let it be extractions due to MIH, are the important criteria that you have to make a note. So followed by the criteria, the patient have complaint of pain and hypersensitivity. Those 2 lines are very very important, very frequently added to your questions. Okay, then differential diagnosis. So they are very other important. How can you differentiate enamel? Amelogenesis is imperfect. All the teeth are affected. Mother or father or siblings are going to have the same complaint. Okay, next followed by the second one. When I'm talking about the fluorosis, it is a time based, means how much amount of fluoride exposed, what time it is exposed. So basing upon you have Turner's hypoplasia is at a single particular teeth, preferably mandibular premolar. Okay, and followed by enamel hypoplasia, you have a different thing. White spot lesion is related to the caries. Syphilis, same area specific, but you have a different origin. You have a background history. You have a mother suffering from syphilis. Okay. Other features of syphilis can be added in a syphilis-based question. Coming to the treatment, molars with breakdown, different treatment; without breakdown, different treatment. Anteriors, you have 3 different treatment plans. One is white cheesy, second one is brown, yellow to brown color opacities, and third one is a normal opacities in an individual more than 15 years. Okay, so I mean, like, before concluding this from examination point of view, maybe in the future you may get exposed to this particular case in your clinical scenario or where you're working anything. So it's always, learning is a big process. It's not only, this topic is not only from entrance point of view or a university exam point of view. The main consent of this topic is to learn, is to implement in your clinical practice or implement to a particular situation in the future. Okay, so this is all from my side. Okay, so as of now, signing off, Dr. Srikanth from Team MDS CONQUER. Take care. Bye.